streaming spine surgery from the Deuk Spine Institute. And our patient here today has undergone multiple back surgeries in the past, not by us, by other surgeons. He comes from the great state of Mississippi, and he has had back pain for 20 years in his lower back. It is December 20th, 2022. We're getting ready to ring in the new year. But this is one of our last few patients for the year of 2022. When I asked him where his back pain had been, this is what he said. It's in this area right here. And we just started streaming, so the beginning of the surgery, we had some technical stuff going on, but we've got it resolved. And you can actually see we've done the discograms already. And we tested the L4-S1 disc, which has the biggest herniation, pinching his nerve. And basically the disc at L4-S1 is a 10/10 pain. It's concordant, meaning that's where he gets his back pain all the time. The L4-5 disc is a 9/10 pain, and it's concordant as well, meaning that's where he gets his pain every day. Now, he's going to represent a very challenging surgery, and we've had a run of what I call level 10 surgeries at Deuk Spine. The last two lumbar Deuk laser disc repairs we did last week were 10s. And one of them was a 10 because he weighed 400 pounds. His spine was very anterior. He was very difficult to do, but we finally got him. He maxed out all of our instruments. I saw him the day after surgery, 100% pain relief. All of his pain that he lived with for years was gone. Very happy. And he's actually works at NASA, and he works for Lockheed Martin. He's an engineer, software engineer, so important job. And I always talk about these guys, you know. I talk about NASA, defense, software engineering people all the time. Why? Because these people, when they're in pain, they take narcotics to release their pain, which is the wrong thing to do. But narcotics can affect your judgment, thinking, your math skills, your engineering skills. So what we don't want to do, we don't want to shoot that rocket and have it turn around and come back and hit us. And so you want to make sure the math and engineering is right. And people who are in pain, they can't focus very much. They're having trouble. It's distracting. So we were able to get rid of his pain, 100%, and he was so happy afterwards. All right. The second level 10 we did last time was also a patient who had prior back surgery, a fusion done at the Villages in Florida. Terrible fusion. Wasn't done properly. Either way, the surgeon didn't treat the L3-4 or the L5-S1 disc, and they needed to be treated. We got her done, and her pain was 100% gone the next day when I saw her. So 2 home runs. We were batting 1,000. Now this patient comes to us from Mississippi with 2 bad discs. The 5-1 disc has been operated on several times, at least 2, and there's massive amounts of scar tissue in there from his surgeries. But the surgeon left the herniation. I'm going to do my best to take it out. So we're going to get started. We've already done our discograms, 9 out of 10, 10 out of 10. We're going to start at L5-S1. You sure you want to start at L5-S1? Why don't we start at 4-5? We're going to start at 4-5 just because I want to get this other needle out of the way. So I want to do 4-5 first so I can pull the needle out, fix that disc, and then we're going to come to 5-1. 5-1 will be the hardest. All right. I'm going to place the guide wire, take the needle out. You can see the guide wire is still in the disc. Show us the guide wire tip in the disc, Jordan. Okay, you see the white arrow areas on the x-ray?
Yes.
So switch to the x-ray. You can see the white arrow. Show them the shaft of that guide wire. There it is. It's entering the back of the disc. Show them where the tear is, Jordan. See the tear? I want you to pay attention to the tear for just a moment. Look at the stalk. It looks like a mushroom. Show them the mushroom growing sideways. So there's the stalk and there's the cap. He's showing you the cap. There's the stalk. There's the cap. The cap is the part of the herniation that's sticking outside the disc, interacting with the nerve root. Show them where the nerve root is. The nerve root exits circle right around there, underneath that bone right there, the pedicle. Show them the pedicle. So you want to know where the nerve root is, find the pedicle, show them the bottom of the pedicle, that black line, yep, and then the nerve root sits underneath the pedicle, right where he's pointing in that circle. And then just below that is the herniation, okay? As the nerve root exits, it goes down and out. So it's going to course, down from the nerve root position, there, and down and forward. Forward. Yeah, but come down and make a little arc just behind the herniation. There you go, perfect. That's where the nerve root runs. So the herniation is actually interacting with the nerve root, causing leg symptoms. Okay, our goal today is to remove both parts of the herniation, the part that's sticking out as well as the part stuck in the annular tear. Show them the part stuck in the annular tear. That part right there, that's the annular tear, and that black is the nuclear material stuck in the tear. We want to get rid of that and clean it out. Perfect. So we're heading into the disc herniation right now as we speak. I'm going in through the tear that's already there, so we're not doing any additional damage to the disc itself. Shot? We're actually going in to the damaged part of the disc, which is better for the patient because that way the patient doesn't have more damage to their body. So you see we're passing through his tear that's already there. I just shoved some of the herniation literally back into the disc, so I'm going to go in there and retrieve it now. That's the beauty of this technique. It's called the in and out technique. It means you're starting on the inside of the disc and working your way out through the tear. All right, done. Now I do want to make an announcement for the population. Are we broadcasting?
We are.
I want to congratulate Arias on having 2 papers accepted to the Southern Neurosurgical Society meeting. Okay, thank you. We submitted 2 new research publications with incredible data. One of them was on thoracic Deuk laser disc repair and how effective it is. And for herniated disc in the thoracic spine, it was accepted. And then the other paper was on comparing Deuk laser disc repair cervical patients with cervical disc herniations to anterior cervical discectomy and fusion patients with respect to the use of postoperative opioid narcotics. And we found that fusion patients required a lot more narcotics than Deuk laser disc repair patients. It was significant, the difference, about 750 times more for the fusions. So if you don't like narcotic, opioid painkillers like the rest of the people, they're dangerous, you may want to consider having a better option for surgery than an ACDF. And that paper was actually recognized, by the way, this everyone should know, is a top 10 paper. How are we doing? Good. Meaning he's not too squirmy, so you can keep him lighter if you want. What that means, folks, is that it was one of the top 10 papers submitted for publication to the meeting. It was recognized. So now it's going to be entered into a competition where the executive committee votes on it at the meeting to see if we get a prize. All right.
We have a question from our audience.
Wow, already. Wonderful. I will take the question.
S. Dell on YouTube says, Dr. Deuk, congratulations for your paper being accepted. My question is, how do you measure disc inclination? By using MRI or using fluoroscope? Do you have any special method?
All right, well, the question is, how do we measure disc inclination? Do we use MRI or fluoroscope? Thank you, Estelle, for your kind words. I don't measure disc inclination. I'm not sure what you're really asking, but that's not a concept that I use. I'm not sure if you're talking in the context of fusion surgery or Deuk laser disc repair surgery. I don't know if you're talking about the L4-S1 disc specifically relative to transforaminal endoscopic surgery. So I'm not really sure what the context of the question is, but I don't measure disc inclination. Inclination to me is a measure of an angle. So I'm not sure if that's the right word or if it came out wrong on when you typed it. So I'm not sure. I can't give you an answer because I don't really understand the question, I think. All right, this blue stuff is all herniated nucleus pulposus. Remember, where are we right now? We're in the stalk. of the mushroom. We're in the stalk, the thick stalk of the mushroom. We're taking it out. It's called the interposed herniation. Interposed herniation. This is the part of the herniation other surgeons don't take out. This is the most important part of the herniation to remove, because this is the part that keeps the disc from healing and causes more herniations. That will be another paper, Arias, we're going to be writing someday, is how many herniations, herniated fragments, does the average patient have in their herniation? Everybody thinks it's just one, but it's not. It's multiple. And we have to show the world it's multiple. By the way, here's the tear. You can see the annulus on the right side, the white, and you can somewhat see it on the left, but it's got this jelly stuck in it, okay? And that's what we're cleaning out with the Deuk laser disc repair. We can do it lumbar and cervical. I think we should do it for both. The irrigation's good, by the way, today, guys. I don't know what you guys are doing, but it's working.
This is our last DLDR for 2022.
This right here?
Right, yes, we were talking about
Wait. So the other 3 cases we have today are all Deuk plasma?
Yeah, PPRs.
Oh, wow. Very interesting.
Yeah.
So Dr. Berndes has just informed me this is our last Deuk laser disc repair for 2022. So we will not be broadcasting the other surgeries today. This is the only broadcast because we're not broadcasting the Deuk plasma rhizotomy. All right, let's talk for a moment about that. What is the #1 cause of back pain? All comers. The answer is herniated disc. And 85% of people with chronic back pain have a herniated disc as the cause. I use the word herniated disc because that's the proper term to use. However, there are other terms for it, and they all really mean the same thing. Bulging disc, ruptured disc, protruding disc, extruded disc, herniated disc, extruded disc, prolapse disc. All of those things, degenerated disc, they all basically mean the same thing. And what they really mean is there's a tear in the wall, which we just showed you on the x-ray, and that tear has the jelly from the center sticking into it, trying to escape the disc. And that tear is full of this blue stuff, this nucleus, which is creating pain inside the tear through a process called inflammation. Arias, are you able to run a video animation?
Yes.
Would you be kind enough to run the video animation that shows how does herniated disc cause back pain in the lower back, if you have that loaded up? This is a perfect screen capture for a paper. I don't know if you can mark this right on a post-it. The time point right now on the video, whatever the time point is.
Pause it, I can snipping tool it.
But just look at the time point on the recording and come back to it. But look at the tear right there. You can see the annulus on the right, annulus on the left, and there's a tear right in the middle, and the blue stuff is in the tear. That's a beautiful picture to highlight the annular tear. That's what we debride with the Deuk laser disc repair. Gets rid of the back pain. Do the same thing in the neck, we get rid of neck pain. Same thing in the thoracic, get rid of thoracic pain. This is the interposed nucleus right there. It stains blue with the blue dye because the nucleus, degenerated nucleus, stains blue. All right, whenever you're ready, you're welcome to run that animation video.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. Hopefully you've watched the animation and you can see now how a herniated disc causes back pain. Dr. Berndes, my anesthesiologist, and I were just discussing the timing of the anesthesia for these patients. And I was talking about how each disc, you can tell once you're in there, just how bad the damage is. You can see this kind of whitish stuff right here is dense scar tissue. And then the gold stuff, when the laser hits, is calcium deposits. So the white stuff is scar tissue with calcium deposits in it. When it gets hit by the laser, the white stuff should turn to gold. You see that? It's turning to gold right there. It's not real gold, by the way. So don't get any ideas. Don't try to make a necklace out of it. Basically, the gold is just the coloration as I'm talking about. And the reason it changed to gold color is that calcium, and when you put laser energy on it, it literally turns it to a gold color. I don't know why. It's some type of a reaction where you're energizing the metal. Maybe you're changing it, oxidizing it perhaps. Not really sure. I think it's an oxidation, massive oxidation process suddenly happening. All right, this is the back of the L4-5 herniation, and those are fibers of what's called the annulus fibrosus that I'm going through, the final fibers, and that's where the annulus literally blends in to become the posterior ligament. So, posterior longitudinal ligament. So that there's a junction between the annulus fibrosus, which is 25 layers of collagen wrapped around in a circle like an onion around the center of the disc, holding the jelly in place in the center. That's where the annulus meets the posterior longitudinal ligament of the spine, which runs behind the disc and stabilizes the disc. All right, we're just about done. This is L4-5. We haven't done the really hard one yet, L5-S1. L5-S1 is going to be super hard because it's been operated on already by multiple doctors multiple times. It's full of scar tissue. There's lots of damage to the structures of the spine in there already. I try to keep people from getting microdiscectomies and laminectomies. I warn them about the horrors. Some people think, oh, well, because my surgeon recommended it, that's what I should do. Well, your surgeon's recommending it because they don't know how to do this surgery, which is a far better surgery for you. Okay? Any other questions, Arias? All right, this patient had, what did he have at 4-5? 9 out of 10 pain? Yeah, 9 out of 10. He had 8.5, we rounded it up to 9.
Can you get calcified spicules in the nucleus pulposus, or that's not?
No, you cannot get calcified spicules in the nucleus. So the reason why you see these calcified spicules so deep is because when you get a tear, the tear goes from the outer annulus to the inner annulus, right? And the inner half of the annulus normally doesn't have any inflammation capability because there's no blood vessels or blood supply to the inner half of the annulus or the nucleus. But once you get an initial injury, okay, and that tear occurs full thickness and you get the nucleus coming out, you get inflammation in the outer half, but then that grows down into the inner half over years of inflammation. Remember, inflammatory tissue grows. We call it proud flesh in the South. When you have proud flesh, that's a massive inflammatory tissue sticking out.
That's keloid almost. They call it in the skin.
We have a few questions and comments.
All right, hold on. We're done here. I'm looking over here. Oh, there's a little bit left right there I want to get, just underneath the nerve root. Well, yeah, it's a keloid, but not really. Keloid is kind of post-op, but people get proud flesh when they have chronic inflammation, like a boil or something. that just keeps going because they never get rid of the source of inflammation, the foreign body, whatever it is. All right, yes, we'll take the question.
All right, we have a few comments. 3 comments from Stephanie. She says, they say, amazing repair, ready for mine to be repaired. Merry Christmas to you and your team. And then we have a question from Estelle.
Hi, Stephanie. Thank you for your comment. I'm looking forward to helping you. And I think I know who you are, but I can't say anything for patient confidentiality. But looking forward to watching your son race. I'll just say that.
We have a question from Estelle.
Yes.
Estelle on YouTube says, Dr. Deuk, between interlaminar and transforaminal, which is your preferred technique of disc repair and why?
Estelle, I love it. It's so nice to have you here, Estelle. I don't know who you are, but you sound like you're a surgeon, a spine surgeon. You've asked an incredibly good question, Estelle, and now I understand your L4-S1 inclination question. You know, Estelle, for those of you who don't know, is asking an incredibly insightful, intelligent question. It's about this bottom disc here, L4-S1. Endoscopic spine surgeons around the world consider transforaminal surgery at L4-S1 to be virtually impossible to do. And what that means is you're going from the side through the foramen, which is my preferred choice. That's how I do all my L4-S1 is transforaminal. The problem is, technically, it's extremely difficult to do. So most spine surgeons that do endoscopic don't do it. They don't even try. Instead, they go straight down translaminar. But to do that, you have to remove the lamina, part of the facet, and you have to remove the ligaments between the lamina, and that destabilizes the spine. So you basically defeat the purpose, in my opinion, of doing this endoscopic surgery, transforaminal, because you're now removing bone and ligaments from the spine that you don't want to remove. So my preferred treatment is transforaminal at L4-S1. I've never gone translaminar when I tried to go transforaminal. Of course, I've done thousands of translaminar approaches open. I don't find it necessary. I've had to abort maybe 1 in every 100 L4-S1 transforaminals because the patient is usually has some type of very unusual anatomy. Whether it's, usually it's the spine is extremely anterior and the patient is very big, physically large. Therefore, access to the L4-S1 becomes more challenging. The reason Estelle is asking this is because the iliac crest, which is the bone that comes up in the back here, actually can actually block access to the L4-S1 level, because the iliac crest comes up to L4-5. So a lot of surgeons believe you can't get to the L4-S1 transforaminal because the iliac crest bone will block it. But that's not the case. I've done 1,000 of these surgeries at L4-S1 transforaminal, and I've only had to abort maybe 2 or 3 in my career. And I've had to abort them not because they're normal anatomy, but because the patient has like a listhesis grade 2 or 3 with a very anterior spine, and they're really big patients. So, or they've had fusion done at L4-5, and the fusion mass is extended laterally and inferiorly, and it's blocking access. Or the facet joint is really, really enlarged, like 5 times bigger than it should be, and I can't get past the facet. So those are the cases where I've not been able to go transforaminal L4-S1. In general, I never go translaminar because I don't believe it's a better procedure. It's a worse procedure. You just have to get really good at doing L4-S1, which I've gotten very good at it. Okay, we're going to do L4-S1, and this is the disc that the patient's already had multiple surgeries by other surgeons. They did laminectomies, discectomies, all of them have failed. And now he's here from Mississippi to have me do the laser. I would much rather have been the first surgeon here fixing the L4-S1 and not being the last surgeon to come in here, because it makes it infinitely harder for me to do the surgery when they've had prior surgery. there's a lot of scar tissue, and there's distorted anatomy. I've had to be very careful. I'm going to show you what I'm talking about. We're going to get a quick AP view in just a moment, and I'm going to show you how on the side view it looks relatively like a normal L5-S1 shot, but on an AP view you're going to see that all the bone is removed from the lamina. This prior surgeon has removed all of the normal lamina bone at L5-S1. Let's get an AP. All right, now show them, take a little bit better one. Actually, let's see if we can get a little bit better. Try again. I think we're off on rotation. That's good. All right, now, Jordan is going to show you with his white arrow. On the right side, show them the edge of the bone. Okay, right there. A little bit to the left. You see the black edge there? Now, to the left of that, show them the left. The white stuff is all removed bone, gone. Okay, and then on the other side, show them how the bone is still there. Yeah, that bone is still the residual lamina on the left at L5, okay? So that surgeon basically took out so much bone and there's all scar tissue there. And we're still coming transforaminal. You can see the tip of the dilator is transforaminal. We're coming in lateral to the facet, and we're going to hit that disc. No, take one more AP. All right, good. You see how I just advanced the dilator? Let's go lateral. All right, so we're about to enter the L5-S1 disc. Now, for S-Del, I want you to know I've done something in this patient, a little bit of a deviation from normal. Normally, I would go to L5-S1 right here. Can you see the eye in the sky, Arias? I would start right about here. But I went further lateral. The further lateral you start, the more medial you can get at the center of the back of the disc. And he has a medial herniation, paracentral. So I really want to go as far to the, starting as far lateral as I can to reach medially. Shot?
We have a comment and a question.
Yes.
Sherry Buzzmelver on Facebook says, horses get proud flesh also, and very hard to get rid of on their lower extremities.
Yeah.
And then we have a question from Mocha Bokal on YouTube. Mocha asks, great job, doctor. How long will the recovery time take?
Thank you for asking. Sherry, thanks for the comment on the horses. Yep. It's granulation tissue, very firm, very tough, and we don't want that, obviously, in a patient. Pull back the dilator just a little bit. The recovery on this patient will be 1 hour. We're going to be done here in 20 minutes, and then the patient will go to recovery room, and he will spend literally an hour in recovery and then go back to his hotel. Done. Okay? So what I'm getting at is Deuk laser disc repair is outpatient. It takes a 1 hour recovery. You can be back to driving, working, shopping, normal activities by the next day. A lot of our our patients go employees. A lot of our patients go back. I guess they are employed, but they're not our employees. They're our patients. They go back to work the next day because they don't want to miss work. Now, if this patient was having open back surgery, they would be in the hospital probably. And in his case in particular, since he's already had 2 back surgeries before with all that bone removed, the surgeon wants to fuse him. Now, I'm going to tell you a little secret. If he had gotten ahead with the fusion at L5-S1, he would be back for more surgery within a year or 2, okay? Why? Because the surgeon was only going to fuse L5-S1. They didn't even consider L4-5, even though L4-5 needed to be treated as well. It was a 9 out of 10 in pain. That's the biggest problem I see among spine surgeons, is they're under-treating the patients. They're not treating all the discs that need to be treated. I've asked myself, why would they do that? And, you know, my father brought me up the right way. He told me, when you do a job, do it right the first time, so you never have to go back and do it again. And I believe that. And ever since I was a kid, that's what I did. I always did my best the first time. So over the years as a spine surgeon, I've learned what are the things I can do for the patient before I do surgery that's going to give the patient the best chance of having just one surgery, one treatment being done and being out of pain. And one of the biggest differences is basically treating all the discs that cause pain with the first surgery. The reason surgeons don't do that, I'd like to believe, and I could be wrong, but I'd like to believe it's because they don't know any better. But there is surgeons I know for a fact, surgeons that actually will treat one disc at a time just so they can keep making money on the patient over the years. They give the patient a little bit of pain relief, like a druggie, like a drug dealer. They give you a little bit of drug, get you hooked, and then the patients keep coming back for more surgery. I am 100% sure this happens out there. I don't know which surgeons do it. I know of one that does it locally. I'm not going to mention any names. But it's a shame that doctors treat patients that well. I don't think that's ethically right, morally right. Therefore, I always do all the discs needed to be done in one surgery. And it's reflected in our what's called our reoperation rate at Deuk Spine. Our reoperation rate is less than 1%. That's because we get things right the first time. That said, a lot of our patients that have disc injuries also have facet pain. And we're not fixing facet pain right now, we're fixing a disc. So the facets are a separate joint located behind the disc. And about 20% of our patients that have the Deuk laser disc repair, we cure their disc pain or disc problem, and then they come back with facet pain, and we have to treat that. As a matter of fact, one of our surgeries today will be a patient who had the Deuk laser disc repair done at a couple of discs, and his back pain was gone immediately, but he had some facet pain, which he had before the surgery, but didn't want them treated at the time. So we waited to see if it would go away, but it didn't. So he's coming back for facet treatments. All right, what questions do you have? By the way, this is a herniation right here I'm working on. It's so big, I'm having to cut it in half with the laser. And then I'm going to take the pieces out a little bit at a time so it's easier to get out for me and the patient.
We have one comment from Estelle on YouTube.
Yes.
Estelle says, thanks, Dr. Deuk. Myself, an orthopedic resident, interested in endoscopic spine surgery. I want to say that you are the best endoscopic surgeon to my knowledge.
Oh, thank you so much. And when you're done, wherever you are, if you're in the States, look me up. I'd be happy to talk to you about your future. Yeah. I appreciate that. And it's good to know that there's a surgeon who has passion and knows what they want, and they take the time to learn new things. That's a great sign, wherever Estelle is. I'm sure Estelle is going to be a great spine surgeon wherever you end up working and training. To have the initiative to come and watch these surgeries outside of their regular curriculum is wonderful. By the way, Estelle, I was trained primarily for lumbar, what you're watching right now, by an orthopedic spine surgeon, Dr. Anthony Young, Y-E-U-N-G, Tony Young. I'm one of his proteges, and Dr. Young is now retired, but I have the greatest admiration and respect for him. I consider him to be my greatest of all teachers in the spine. And I love him dearly. He's a great man. He's not just a great surgeon, but he actually has fought to make these procedures available to people in pain, suffering. And I share a lot of his philosophy in life about helping people in pain. I hate to see people suffering in pain, especially now that we can cure it. It's unfortunate that people get caught up in all these pain management clinics that don't really fix them. They just keep doing procedures that really aren't good for the patients, and patients end up having a lifetime of pain because they can't find a cure. Well, the cure is now here. It's the Deuk laser disc repair. It's the unique surgery. It's nothing like this is done anywhere else. There is endoscopic surgery done, but it's not the same as the Deuk laser disc repair. Deuk laser disc repair is a special type of endoscopic surgery. All right, do we have more questions?
One question
Uh-huh.
from Sue Griffin on Facebook.
Hello, Sue from England. How are you? Hopefully you're well.
Sue says, with fusion, is it also the case that with some surgeons, the more levels of fusion they do, the more risk of failure/complication due to skill level?
Sue asked a great question. Dr. Deuk Majin, when fusion is done, can you say that the more levels being fused equals a higher chance of complication? The answer is yes. It's well established that the more levels being fused result in a higher level of complications. The reason for that, is, of course, is the more levels you're fusing, the longer the surgery is going to take. For me, when I'm fusing in the lumbar spine, it's an hour per level. So, and I'm a very fast surgeon. Most spine surgeons will take 3 hours per level. I take an hour per level, just to give you an idea of the difference. And that's also, by the way, they're not even doing as the same quality of fusion as I am. So that's why a lot of surgeons, I talked earlier about why do surgeons undertreat patients, they don't treat all the levels. Part of that is too that it just takes a long time to treat all the levels in the operating room. So some of them are thinking, well, I could do a 3-hour surgery or I could do a 6-hour surgery or a 9-hour surgery. And honestly, 9 hours is not good for the patient. And they're right. 9 hours under anesthesia is bad for the patient. But what they really should be saying is, am I really good enough to do the surgery? Or should I refer the patient to a doctor who is better? And honestly, if that was the case, 90% of spine surgeons would close their doors. I hate to say it, but it's true. And the 10% of us that are really good at what we do, we would be doing all the spine surgery. Unfortunately, the opposite is happening. More and more unqualified spine doctors are coming in and doing treatments, and I'm even seeing totally inappropriate doctors like anesthesiologists or neurologists doing surgeries on patients' spines, which they shouldn't be because they're not surgeons, okay? So that's happening, and nobody is stopping it. Why is it happening? Because they represent a cheaper option for patients. They always charge less money. So the patients like it because they're paying less money, but they're also getting far inferior quality care. And God forbid, you're having an anesthesiologist do your back surgery, God forbid they get a complication. They're not going to know how to fix it. That's something in the realm of spine surgeons, neurosurgeons, and orthopedic surgeons. We're trained to do surgery and deal with complications properly. And I can tell you this, if you get a complication in spine surgery and your surgeon doesn't know how to deal with it properly because they're not a surgeon, then you're going to be up shit creek without a paddle, I can tell you that. And that's not good for patient care. So I think this whole concept of expanding scope of practice, you know, and letting anesthesiologists do spine surgery or pain management doctors do spine surgery is really bad for our patients in this country, and it needs to stop, in my opinion. The only reason they're doing it is greed. They're not trying to help the patients, they're trying to help themselves, and that has to stop. It's only going to make complications and bad outcomes more prevalent. All right, we'll take some more questions. We're just working away at this herniation at L4-S1. It's huge. I am going to get it. I feel really confident. 15. We've got about 15 minutes left. By the way, if you look right there, that little window, you can see bone. That's actually the surface of the S1 superior end plate, it's called, superior end plate. And all this blue stuff I've been removing is the herniation. It's the inside of the herniation. All right, questions?
No current questions.
All right, so Arias, tell me, did Henry get back to you and help?
Yes.
That's awesome. So our regular videographer is actually on vacation in Israel, in Tel Aviv, and we had a technical issue this morning, which is why we started a little bit later than normal, but we were able to communicate with him through I guess, text and resolve whatever issue we had. I think that's pretty cool.
I sorted it out on my own, actually.
Good job, Arias. Good job. I'm proud of my team. All right, so we are at the second disc that we're fixing. This is the L4-S1, the more difficult one. And the herniation that I'm most concerned about, I've been whittling away at the base of it, the stalk, and we talked about the mushroom concept, where the head of the mushroom is the part that sticks out where the nerve is up here, and that the base of the mushroom is sitting inside the annular tear. Okay, that's all fat, by the way, I just destroyed. I don't think the patient will be unhappy about that. We don't charge extra for the liposuction, but it is sometimes necessary to gain access to the herniation in the epidural space. Because now I'm in the epidural space. This fat is in the epidural space, okay? What is the epidural space? It's the space behind the disc. When you see fat, you know you're not in the disc anymore. You are outside the disc. And that's where we want to be. Remember, this is the inside-out technique taught to me by Dr. Anthony Young, an orthopedic surgeon, what I consider the greatest lumbar endoscopic surgeon in the world, who's now retired, was in Phoenix. His son, Chris, is taking over his business and surgery center. And Dr. Young, that's the herniation. Dr. Young taught me, but Dr. Young also doesn't use the laser. He uses a different device that doesn't work as well. I won't say why, because I respect him too much, but let's just say there's financial reasons, okay? And I'll leave it at that. I don't believe in doing financial reasons for patients. I think you should always do the very best you can, but I understand his reasoning, okay? All right, so now I know there's still herniation there. I'm going to want to use something very special called Grabzilla.
Oh, Grabzilla, please. Oscar, Grabzilla.
Okay? Yeah, I think to get this herniation out, we're going to have to bring out Grabzilla. Grabzilla is just a play on words. Obviously, for those of you who know who Godzilla is. See the little biter here, the little biter? It just doesn't do the job. Grabzilla, I'll show you the difference. Let's turn the light on. Scope off. Aria, switch back to the overhead feed. Can you
Copy.
see it?
Yep.
So we're going to bring in Grabzilla because this is a big job. We need a beast. For those of you watching, this is the incision right here. I'm going to show it to you. Can you see this? The whole surgery is done through a 7mm, 1/4 inch incision. We can do up to 3 discs with this one incision. All right. Now, before you introduce them to such a scary monster, can you see this, Arias?
Yes.
All right. Now that's the standard grabber, pituitary rongeur, endoscopic. Put Grabzilla next to it, Grabzilla's mouth. All right? Oh yeah. No contesto. Okay? This is like Mothra and this is Grabzilla. All right. So we're going to bring in Grabzilla. And Grabzilla does a really good job for those of you who do endoscopic. It's got an articulating head, so I can actually use this lever right here. You see the lever, Arias? See this lever?
Yes.
All right, so not only can we grab, but I can adjust. Look at the angle there. See that action? You see that action? Grabbing up and biting? That's exactly for the kind of herniations I'm dealing with right now. So I'm going to go in, watch the tube, stabilize the tube, don't let it go in or out. And I'm going to go for the big grab. Try to get this giant herniation out of here. All right. Oh, there it is. You see that? Grabzilla did his job. Arias, can you see this thing? I'm
Yes.
sorry, I get a little excited. That is the herniation, folks. Beautiful. Grabzilla did his job so well. I'm so proud. Bring him some radiation. All right, let's go take a look. I don't know if there's more than that, but that was a big herniation. Yeah, oh yeah, here. Can you see this, Arius? Bam, 2 centimeters.
Yes.
Okay, there you go. Merry Christmas. Right? Our patient's snoring away. I put it right here. You guys see how it's blue? That's the Deuk spine blue, right, Dr. Berndes? Anybody have any questions for me? So, SDEL, you can see transforaminal can be done at L4-S1. It just requires great skill and experience, okay? And most surgeons don't do it because they're not capable, they don't have the experience, and maybe they've been told they can't. I was never very good in life of being told I can't do things. I've always challenged that belief and tried to do it better. And I've been doing this now 16 years, this surgery, okay? And like I said, we've had really good success at L4-S1. So I'm not worried about it at all.
We have one question on YouTube from RT.
Uh-huh.
RT asks, why are some/most neurosurgeons scared to deal with thoracic disc bulges/herniations?
Oh, there's still herniation in there. I think I'm going to bring Grabzilla for another bite. Okay, RT is asking a great question. And he's saying, why are so many surgeons, stabilize the tube, so worried about doing thoracic disc herniations? The reason is very simple. Thoracic herniations are the realm of neurosurgeons, not orthopedic surgeons, period. Okay? And the reason is that the thoracic spine has a spinal cord. The spinal cord is so delicate, and it's right there in a very narrow space in the thoracic spine. And because of that, it's very easy to damage the spinal cord in thoracic spine surgery. So orthopedic surgeons don't even touch it. There's half of your spine surgeons right there who won't even go near the thoracic spine. Okay? Then you've got neurosurgeons, and 90% of neurosurgeons truly are not competent enough to do thoracic spine surgery that comes close to the spinal cord. They're just not trained. So really what we're dealing with is a situation where out of 6,000 plus spine surgeons in the United States, only about 5% of them can do thoracic spine surgery safely. And by the way, a lot of it has to do with their hospital. Not just their training is inadequate, but the hospital they work at doesn't have the resources, the equipment, the staff, the know-how to do such complicated surgery. Because again, the spinal cord is involved. We're removing piece after piece after piece of this herniation. It's pretty impressive. I'm going to go back in with the scope and take a look. We've just taken out, not as big, but another 3 or 4 pieces that equal the same size we just took out with the big one. So we're making great progress here. I think this patient's going to do fantastic. I'm very pleased with what I'm seeing. Okay, so the thoracic spine is very hard to fix because technically most spine surgeons don't know how to do it. They're not trained in their training program. That's something you guys need to understand. I've talked about it before. Not all spine training programs are equal. You know, I went to literally the best neurosurgery training program in the world. And I only was able to do that because I was literally top of my class. Oh, yes, more herniation coming out. So the best neurosurgery programs in the world, they want the best medical students in the world. And you have to come from not just the top medical school, but you have to be the top of your class at the top medical school to get a position at the best training program, okay? And it's not something you can buy yourself into, at least not yet.
We have 2 longer questions.
I'm going to get to them in a minute. Thanks, Aris. My point is, quite simply put, that to get the best training in neurosurgery, you have to go to the best training program, and you have to You have to then, when you're done, get out and have access to the equipment at your hospital, which 90% of hospitals can't do complex thoracic spine surgery. Trauma centers can. That's where most complex thoracic spine surgery is done, is at trauma centers, level 1 trauma centers. And most cities have a level 1 trauma center where it can be done. But I can tell you this, the surgeons that do thoracic spine surgery, they focus more on very, very bad injuries, like fracture, dislocation from a car accident. So their time is spent dealing with trauma. They don't deal with degenerative conditions, like herniated disc. But Deuk Spine Institute has now developed endoscopic surgery to deal with thoracic disc herniations. It's very safe. And as I said earlier in this broadcast, we've now had accepted for publication a paper with our results of our surgery. Now, Dr. Berndes, this is taking a little bit longer than I thought, so probably another 10 minutes. But we're making great progress. All right, Arias, I'll take the additional questions. This is still herniation right here. I got to get out. Arias, the questions?
Sorry. Yep, so we have 2 questions on YouTube. One question on YouTube, apologies, from Ruzba Taimori. Ruzba asks, what are the percentage of cervical hernias that spontaneously regress, and what are some activities to promote that? Also, what is the impact of posture in promoting that?
Hi, Bruce. How are you? Thanks for the question. Question number 1. What's the percentage of cervical disc herniations that spontaneously regress? The answer is 0. They never do. It's a farce, a lie, a myth that herniations go away on their own. For some reason, it's pervasive. What goes away on its own is the symptoms of the herniation. So in other words, the herniation is still there, but the symptoms have gotten better. And they will come back. They get better for a short time and then they come back. So everybody thinks, hey, I got a herniation, I'm just going to wait it out and let it go away on its own. They don't go away. It's like a tumor that doesn't go away on its own. It just gets better because you take it easy. You know, you modify your lifestyle. You start sitting on the couch more. You don't exercise as much. Maybe you take some pain meds. It helps ease it when it's bad. But the reality is that you adapt to the herniation. And you adapt and evolve your behavior and modify your behavior. And I'm going to say this, those modifications are not good. Okay? People with bad backs that have pain when they're active, they start sitting around, you know, doing less physical activity. And the back pain can rob you of the quality of your life. Instead of going out with your kids and doing stuff, you're in too much pain. You don't want to do it. Maybe you start drinking alcohol and doing wine and beer all the time just to treat the back pain. We call that self-medicating, okay? Or maybe you do marijuana. Maybe you do prescription opioids. The point is that some people deal with their herniation by taking drugs. Some people deal with their herniation by modifying their activity level. And some people deal with it the right way, which is to get it fixed and then get on with life and do everything you want to do, okay? I don't promote the use of drugs or alcohol to treat back and neck pain. And I don't promote inactivity, the use of behavioral modification, being inactive, having a horrible life. You know, some of our patients have had 40 years of back pain where their lives have been ruined for 40 years, okay? Oh, a piece of herniation right here. It's beautiful. Come on. Oh, yeah. Shake it out. Nice. This is the greatest surgery I've ever done in spine surgery. You know, I've done it all. But the endoscopic transforaminal, this is absolutely brilliant. I didn't come up with it. Far smarter people than me did. But I've modified it to make it better. And honestly, this is the future of all spine surgery for degenerative problems. Not tumors and infections, not fractures, but tumors, infections, and fractures comprise only about oh, maybe 2% of spine surgery. This is a massive herniation. I'm just pulling it out piece by piece. All right. I hope I've answered your question. I've tried.
We have another question
Oh,
from
man, this
Sue
thing is
Griffin
huge.
on Facebook. Sue asks, if you assess a spine and there is a need to replace existing hardware and laser in another area, which do you do first? Assuming that doing both in one surgery is too much.
All right. Let me think about that question, Sue. So once again, you assess a spine and you determine that what? It needs laser in parts and hardware modification in other parts, correct?
Correct.
And what do you do? I would try to do them both at the same time. But if I couldn't, for whatever reason, it's too extensive, then I would just focus on what's causing the patient their worst problem, their worst symptoms. And maybe just doing the one actually will work. You know what I mean? Give them enough relief, they're happy. I'm always a believer in do the least amount you need to fix the problem. But don't ever do too little so you don't fix the problem. My gosh, the herniation just keeps coming and coming. It's incredible, but I think we're getting close to the end. And the reason I say that, I'm starting to see pulsation. Pulsation means that the tissues are moving with the blood pressure. And that's a good sign that things are freeing up. Things are moving more. Just about done. And by the way, like I said earlier, this will be our last surgery, the last Deuk laser disc repair for 2022. We'll be back in 2023 with more broadcasts. But this will be the last one for this year. And then we've got some Deuk plasma rhizotomies next, which we don't broadcast yet, but we will be broadcasting them next year.
Got about 5 minutes.
Yeah, I keep thinking less time, and then I keep getting more herniation. So I wish I could tell you exactly, but I'm thinking 5 minutes. I mean, we're right at the mouth of the disc. You can see right there is the end of the disc, and you can see where it transitions from annulus to posterior longitudinal ligament. This was a pretty big herniation, and honestly, I'm very, very happy with this result because I was really worried that we weren't going to be able to get all of it. Let's go grab Zilla one more time. Arias, do you have another question?
Let's go ball, please. Thank you.
Nope.
All right.
You can set it back there.
Can you stabilize the tube? I tell you, Grabzilla really made it happen today. Grabzilla opened up that herniation. And still feeding like the prehistoric beast it is. All right, that's it. It looks like there's no more herniation. Let's go take a look. I have a feeling his leg pain is going to be completely gone when he wakes up. And like I said, he's had multiple surgeries in the past. Does anybody know just how many surgeries he's had? 3? 3 in the past. And like I said, every one of them has been a failure. They've all been laminectomies, laser, and discectomy, which I'm very much against laminectomy and discectomy because they're so destructive. But that's what most surgeons recommend to their patients. And of course, they recommend that because you're going to come back later and you're going to do more surgery. So they just keep treating you like an annuity, paying every year, which philosophically to me is wrong. I always think about how I would want to be treated by a doctor. I would want to go in and get it done and move on with my life and not have to come back. I actually, for those of you who have listened to me, I had sinus surgery done. I had to have it done 3 times. Every time I went back, something else was done. Because, I mean, it should have been done the first time, to be honest, and I found the best ENT. But that's a problem in healthcare and medicine. A lot of doctors underdiagnose or undertreat. You can call it misdiagnose or mistreat. But I wouldn't want that for any of my patients.
We have a
Hi.
question on YouTube.
Sure.
Rusba asks, what's the role of posture in preventing new herniations?
Oh, I'm sorry. I'm sorry, Bruce. I didn't answer that one. You're right.
No, this is a new question, and it's Rusba, not Bruce.
I'm sorry. Aruspa. Posture. Very important. Good posture. What's the role in preventing herniations? I think if you go around with bad posture, you're putting abnormal biomechanical stress on your spine. And I think you're going to cause more herniations. I think posture is very important. That said, more important than posture, if you have a herniation, is to go and do this procedure, the Deuk laser disc repair, because your disc is not going to heal without it. Okay, posture is not going to correct the herniated disc. It may make it help keep it from getting worse, but it's not going to fix it. A lot of people think yoga, posture therapy, chiropractic, PT, all of those things are going to fix your herniated disc. They don't. They never do. We work very closely with therapy groups, and we've always seen people with bad discs and bad facet joints, they end up keep suffering in pain because the patient cannot get cured with therapy alone. But that doesn't mean therapy is not important. It is. Okay, I think we still got a little more herniation here. Berndes. I'm going to use Grabzilla one more time. The important thing when you go in, stabilize, is you're opening the mouth of Grabzilla. What I mean by that, looks like not much, it's just deflecting. What I mean by that is, as I go in, I literally pull open the mouth of Grabzilla against the inside of the tube. So as soon as the mouth of Grabzilla pops out, it's already reaching for the herniation above at the 12 o'clock position. That's important. And yeah, we're not getting any more herniation, which is a good sign that we're getting very close to the end. There's still material there, and I'm going to laser it. But, go ahead.
Rusba on YouTube had another question. What else can you do to prevent new herniations? And Sue Griffin, also on Facebook, says, wishing all at Deuk Spine a great Christmas and a prosperous new year. Thank you for fixing the neck this year. Awesome team.
Hey, thanks, Sue. Love it. Getting back to the other question, which is what can you do to prevent further herniations? The answer, you're not going to like it, but it's basically to not do anything. To not lift, not bend, not twist, not do sports. You need to have it fixed. People always want to get out of what's necessary, and they shouldn't try to get out of what's necessary. There's a wrong philosophy in the world that, oh, don't get surgery until it's the last resort, till you're going paralyzed. That is the wrong philosophy. It's not even 1% right. Okay? It's what I was taught too as a resident, but it's absolutely untrue. And that's one of the reasons we broadcast, is to share the truth with people. The truth is that when you have a surgical problem, you should have surgery. What is a surgical problem? It's a problem that can only be fixed with surgery. It's that simple, okay? If you have a brain tumor that is a special type of brain tumor that requires surgery and nothing else works, no radiation, no chemotherapy, no endovascular procedure with coiling or glue, if everything else doesn't work and only surgery works, you should have the surgery done. Okay, yes, it's brain surgery, yes, it sucks, but it's your best treatment option, okay? You can't do something less and hope for a good result, because you're not going to get it. You're going to get a horrible result. Grabber. So, same thing with spine. If you have a surgical problem, do surgery. Don't avoid it. But do the right surgery at the right levels with the right surgeon. That's my best advice. And if you have a herniated disc, do the Deuk laser disc repair. There's no better surgery. If you have a facet pain, do the Deuk plasma rhizotomy. There's no better treatment. Okay? I'm sorry the rest of the world hasn't caught up to the advances in spine technology. I can't do anything about that. I can't fix a broken system that's financially motivated to do worse surgery for you. All I can do is inform you. And then from there, you have to make the decisions yourself. Okay? Between the Deuk laser disc repair for herniated discs and the Deuk plasma rhizotomy for facet pain, there is no better treatments in the world. And these cure pain. Great questions from our audience today, great engagement. I thought we would be done by now, but this is the worst level, and you can see all the damage done to this disc by the patient's annular tear and herniation. Remember, it's a two-step process. The first thing that happens is the annulus is torn, and then after that, the herniation occurs. This patient's had 3 surgeries apparently before. They're all done out of state by a different surgeon than me. I never would have done a laminectomy or a discectomy. I would do the endoscopic procedure. By the way, this is not a discectomy we're doing. We're doing what's called the Deuk laser disc repair. Deuk laser disc repair has been peer-reviewed and published. 1 minute. It's its own procedure. It has its own code. It is not a laminectomy. It's not a standard discectomy. Avoid those surgeries. They're destructive. All right, we're going to take any questions you might have for me. We're just wrapping this up. I don't see any more herniation that's pressing on the nerve. I'm going to go in there one more time with the grabber. I'm doing everything I can to go medial, which is towards the middle where the herniation is. So I'm getting out as much as I can. I'm using my tube. I'm leveraging it as a fulcrum to reach as far medial as I can. I'll try to grab one more time with a grabber, but I think we've done a good job of decompressing. Meaning decompression means to get the pressure off the nerve root. And I'm very happy with the results so far. I think the patient's going to do very well. Okay? You never get 100% of disc herniations. No surgeon can. The disc is never going to look normal again. It's always going to look abnormal. Okay? But there's probably, I would say, at least 25 pieces of herniation. So somebody asked me, what can you do to reduce the amount of herniations? It's all about behavioral modification. Reduce your lifting, reduce your bending, and don't do contact sports. But I'm not recommending any of those things. I think people should live a full life, and they should get their back fixed properly. Grabber. I don't think they should put off the proper treatment. Okay? That's just my personal philosophy, professional philosophy. Is our next patient here ready to go? What is the next case? DPR, what is it? Lumbar, cervical, thoracic? All right. Arias, any more questions right now?
No.
All right. I got about 30 seconds left, and then we're done. You guys can see the end plates right there where they're coming together. I'm just getting the last of this herniation. I'm really putting a lot of force on the tube, pulling the tube down so that it reaches at the tip more medial. I think that's really good. I don't see any more herniation. Is that irrigation out? Just saw some bubbles. See how the bone comes to a point right here? That's literally the very back of the disc. Yep, just about done. That's it. I'm very happy with that. Good job, everybody. Go ahead and type up your questions for me. I'll be happy to answer them. But we're done. It went better than I expected for the L4-S1 after having 3 surgeries and lots of scar tissue. I think he's going to be very happy. Arias, don't forget the image we were looking at earlier. Important one for papers. This is Dr. Ari Deuk-Majan, CEO and founder of the Deuk Spine Institute. I'm here with one of my patients, and you've traveled from where to the Deuk Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking solutions and nothing was working. They did work for a short while, but that short while decreased over time. It was shorter and shorter. My husband does research very, very well. Through his research, he found you. We read that you can fix my back, and you did fix my back.
That's right.
And I thank you.
You're welcome. So when did you have the Deuk laser disc repair done and the Deuk plasma rhizotomy?
I had those done yesterday in the afternoon. I am sitting straighter than I have. I'm standing straighter. I'm walking normal. It's like, wow, new me.
Look at that smile right there. I hadn't seen that until just now. So
well, it wasn't there yesterday.
Yeah, it wasn't there before surgery. And how long have you been not smiling because you've been in pain? I mean, really bad pain. How long has the really bad pain been there?
Well, the really bad pain has probably been over the last 5 years. It's something that was really tough to maintain a positive attitude and try to keep a smile on my face and keep Jeff's hopes up. I tend to be a positive person, but there were times when it does drag you down.
Of course, yeah. It's hard living with chronic pain, and especially with loved ones, they have a hard time, you know, relating. Of course, they want to be supportive, and your husband is a very supportive man, obviously. And he's a pleasure to meet. I know he's an author as well. Yes. And so what are you going to do now that you've had the surgery? And you could see actually the Deuk laser disc repair procedure she had done yesterday. You can see right here, we went into the discs that were damaged. You had 2 annular tears. We tested your discs during the surgery, and indeed they were causing your pain. So we verified that with our discogram. And then I went ahead and used the laser to clean up the tears that were causing your pain and get rid of that source of pain for you. And here you are, you're doing fantastic. How much of your back pain from before surgery do you still have?
Oh, virtually nothing.
It's gone.
It's gone.
Cured.
My lower back, I have not been without pain in my lower back until your surgery. It's constant, it's always there. I've never been without it. I'm without it now.
So are you going to go back to gardening?
You bet I am.
All right, very good. And what other things would you like to do now that you have a new back that doesn't hurt you anymore?
You know, the biggest thing I want to do? I want to go fly a kite.
Good for you. Let's go fly a kite then.
That's right.
Well, congratulations on having faith
Oh,
and being
thank
brave
you.
and getting it done.
Oh, not a problem.
Is there anything else you want to say to your fans out there?
I highly recommend Dr. Deuk's Spine Institute, Dr. Deuk personally, to help you fix your back.
Thank you. Appreciate that. All right. Safe travels.
Phew, that wasn't too bad, was it?
It was wonderful. All right. So now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
I'm Dr. R. Deuk Majan with the Deuk Spine Institute, and I'm here with one of my patients who just had the Deuk laser disc repair on her lower back, and she wants to share her story with you. Now, you came to Deuk Spine Institute because you were having back and left leg pain for how long?
Well, the terrible left leg pain, probably about 2 years, but prior, I've had issues since I was 14 years old. So it's been a lot of roller coaster pain since then.
So you've had back pain since you were 14. You're clearly not 14 anymore.
No.
And so that's like 15, 20 years, right?
Yeah, too long.
And so why didn't you get it fixed sooner?
Well, the doctors when I was younger didn't want to operate. They wanted to, I was young. They didn't want to take a chance because all the surgeries then at that point, there was just nothing there that wasn't going to be traumatic to my back and my spine. So I went through physical therapy, shots, decompression. They did that and nothing was really working. And then it eventually kind of got better, and then it would get worse and it would get better, and it was just up and down, up and down.
Up and down. And the reason it got better was the inflammation from the injury to your disc started to get better.
Yeah.
But then you'd have another herniation with activity, and then it made it worse. So
Yeah.
when we were in there, and you can see from this video right here that we were pulling out lots of big fragments of disc herniation. You probably over your lifetime from 14 until now had at least 10, 20 different episodes of herniation, and that's what we saw when we were inside there.
Mm-hmm.
All right, so now you've had the surgery. How are you doing today?
I feel awesome. The only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
Now, you're not from Florida.
No, I'm from Ohio.
So you traveled from Ohio to the Deuk Spine Institute in Florida. Why did you come all the way down to Florida?
There was nobody near us or anywhere near us that had any other option besides either getting a discectomy or a laminectomy or a fusion. There was just nobody was doing anything else. And I knew I didn't want to do that again because I'd already had that done. So it didn't work. And
Didn't work.
I had a really amazing physical therapist that connected me with you, and the rest is history.
Yeah, your physical therapist found us and was intrigued with the surgeries we're doing here
Yeah.
and sent you here.
Mm-hmm.
So what are you going to tell your physical therapist? I call him Dr. Salinas. What are you going to tell him when you...
Oh man, I've already told him. I texted him the minute I got back to our Airbnb. I said, I feel amazing, and I can't wait to tell all the rest of the patients in our Facebook group, like, this works. So
It does. The Deuk laser disc repair really does work. Well, is there anything else you want to say to your fans out there or friends?
my fans and my friends, thank you for praying. Thank you for believing me. I think that's one of the biggest things. There's a stigma around back pain because you can't see it, that people are just faking it, or maybe they're babies. Like, why can't you just deal with the pain? And it overwhelms you. And so to come someplace that believes me and then fixes the problem, and now I'm sitting here and I can be like a fully active mom. So I'm just beyond thankful. Thank you.
Yeah, chronic pain robs people of their dignity and their happiness and joy in life, and also their loved ones, the people that care about them,
Yeah.
because they suffer with you.
Yeah.
Yeah.
A lot.
Well, congratulations and praise God.
Yes.
You found us,
Thank you very much.
and I think you're going to do fantastic.
I'm looking forward to being strong again.
Awesome. All
Yes.
right. Dr. Arjik Majan here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I was, I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration where I could maybe get up, like stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No, I mean, she consoled me. And in the town that we come from, we know a lot of folks. And to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. And you can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser. And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are. And they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation. And how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the camera that what my personality is, but I try to be very polite, and I was apologizing for profusely sweating because I hurt so bad. It's not because of the Florida heat by any means. It's because I hurt so bad. I never experienced pain like that. And like I said, there's no
because you're a redneck too. You know, you're not that far from Florida.
That's
you're
right.
Just up a state or two, right?
That's right. Yeah.
A couple of states. So you're feeling better today. It's been less than 24 hours since
Yep.
we did your surgery. You went home an hour after the surgery, back to your hotel with your
Yep.
lovely family who I met.
Yep.
And how do they feel about your progress?
They're happy that I'm happy. You know what I mean? Because they were scared too. You know, now they were putting on a strong front, but I am just telling you, I was at my wit's end. And I certainly are a lot more appreciative of people who have pain that I'm aware of, because when there's no rest from it, oh my gosh, you know what I mean? I was really at my wit's end, and you saved me. So I appreciate you very much.
You are welcome, sir.
Yeah.
Is there anything else you want to say to your fans out there?
Thank you. Sorry, I could have prettied you up for you a little bit better. So just had surgery yesterday.
All right.
Cut me some slack.
Excellent. And you're heading back home today, correct?
Yeah, right, going back on the plane later this evening. The kids are going to swim a little bit down here in Melbourne. I am just going to rest and watch TV, but then we're going to get on the plane a little bit.
Awesome.
Yeah.
All right. Well, congratulations. You had faith.
Yes.
Took the
I have
leap
faith.
and you got the surgery done.
Yes, sir.
All right. Awesome.
Yep.